Welcome everyone. Today we are delving into a critical emergency procedure, the cricothyrotomy or the emergency front of neck access. In high stakes situation where the traditional airway management fails and you end up with a cannot intubate, cannot ventilate situation, knowing how to safely perform a cricothyrotomy can often mean the difference between life and death for your patients. Having said this, there are a few contraindications that you need to keep in mind. Obviously, if you have an ability to secure the airway with less invasive means, go with that first. I agree that often there are certain conditions where experienced clinicians can proceed with front of neck access directly in certain clinical scenarios, but generally that is not the case. Number two, if there's any airway trauma that renders the front of neck inaccessible, say there's a tracheal transection, say there is a laryngeal fracture, it's going to be hard. Three, if there's children, if children less than 10 years, specifically less than 8 years of age, try not or do not go ahead with a surgical cricothyrotomy. In these people, a needle cricothyrotomy is a preferred approach because cutting through their trachea can often lead to complications, including collapsed airways. Numerous techniques have been described, but my preferred approach is what I like to call the four-step process: the scalpel, the finger, the bougie, and the tube approach. It's a very straightforward process and lets you run through steps in your mind quite easily as well. So once the decision has been made to proceed with the cricothyrotomy, the first thing that you do is extend the neck to identify the anatomy. By extending the neck, you can identify the thyroid, the cricoid, and the cricothyroid membrane. Take a non-dominant hand, stabilize the trachea, and then with your dominant hand, make a 4 centimeter incision over the cricothyroid membrane. Note that this area might bleed a lot. And once the incision is made, you can use your little finger or your index finger to bluntly dissect through the area. Some people like to use artery forceps as well. Dissect through the area till you feel the cricothyroid membrane. Once you're confident that that's the cricothyroid membrane, a transverse incision, say 1 to 1.5 to 2 centimeters at most, should be enough to cut through the membrane and enter the trachea. Note that there might be a lot of splattering of blood once you enter the trachea. So once your finger is in and you've identified and you confirm that you're inside the trachea, you pass a bougie along your finger into the trachea. It's very clear. You hear the tracheal clicks, and once you've gone in 2 to 3 tracheal clicks in, that is more than enough. Passing the bougie forcefully can often result in damage and perforation of your trachea, and that's not something that you want. So once the bougie is inside, you just pass the tube, you railroad it across the bougie into the trachea. And yeah, you're done. And you inflate the cuff, you amboo, verify the position of the tube, and voila, you've saved a life. There are some tips and tricks and some complications that I also like to talk about. The first one is, remember that a front of neck access is a tactile procedure. This is something that my senior colleagues have taught me and something that I continue telling my junior colleagues, that you should be able to do a cric blindfolded. So what we are trying to emphasize is your fingers should guide you and not your eyes, because more often than not, there is so much blood that you do not end up seeing any anatomy clearly. This brings us to our second point, blood. There will be a lot of bleeding. Bleeding is expected, and wasting your time suctioning or swabbing the surrounding area isn't going to do much for you, the procedure, or for the patient. The quickest way is get the tube in, inflate the cuff, and that will cause a tamponade effect, which will automatically stop the bleeding. Tip number 3 is be bold with your cuts. I remember the first time I did a cric, I freaked out and I started making these really small incisions on the skin, like 4, 5, 6 times, which weren't really doing everything. So something that my surgery colleagues love to say, cut like a surgeon. Be bold with your incision, but obviously do not cut through the trachea. Be bold enough to cut through the skin and the subcutaneous membranes. The front of neck is often tougher than what it looks. The third tip is that sometimes when you're unable to identify the anatomy, for whatever reason, whether the anatomy is distorted, whether the patient is obese, or whether there's significant amount of edema, whether there's a hematoma, when identification of the anatomy becomes difficult, you might need to extend your incision, sometimes 5, 6 centimeters, and open up the wound a little bit to actually determine the anatomy. Remember, this procedure requires steady hands and a very, very clear judgment. Practice and familiarity with the equipment is very essential. I know a lot of emergency physicians who've practiced this for a long time but have gone through their entire careers without having done even one. Thank you for watching. I hope the video has shed some light on how to perform an emergency front of neck access. If you have any questions, any comments or tips, please leave them in the comment section below. Don't forget to like, subscribe, and share the video. Stay safe out there, and I'll see you on the next one.